Thank you so much, Dr. Betis, for the very kind introduction. We good on the sound check still? Great. It is a distinct pleasure to be here today with all of you in the room and online, especially those of you in the room. Thank you for braving the cold and the wind chill to come in person and to enjoy lunch together. So I am here to talk about today predominantly the work in the ADVOCATE SGM Health Group, which is really, as you can see from this title, it's really a series of partnerships that's been able to allow us to build the work that we have together that I'm talking about here with you today. And so just to first note, a lot of ADVOCATE is a program housed within the Institute for Sexual and Gender Minority Health and Wellbeing, or ISGM. You can see the logo here. ISGM is actually in its 10-year anniversary year right now. So it's been a real pleasure. And I've been here for the last 7.5 years while ISGM's been around, first as a postdoc and then now as faculty. And ADVOCATE is one of 4 programs and centers that's housed within ISGM. And so we really are focused on clinical and translational research in partnerships with health systems and communities and patients to do the work that we do to really make an impact on the health of LGBTQI+ patients and people with HIV from a life course lens. A lot of the work that we do, in particular in my lab, is focused on chronic health conditions, including cancer, HIV, kidney disease, cardiovascular disease, and diabetes, a number of the conditions that we focus on. But obviously, ADVOCATE as a program is more than just one lab. We also work a lot in partnership with Gender Pathways Program, and ADVOCATE is co-directed by Dr. Sue Jordan, who you see here, who is the medical director of GPP, which is a multidisciplinary adult transgender medicine program housed within Northwestern Medicine. And also, we have a partnership with a new team scientist this year within Feinberg named Dr. Otto Rivera, who directs our electronic medical records data team, which a lot of the talk today will focus on the work of that core. But really, this has been a true partnership on the research side. We see Dr. Jordan here bridging us into some of the NM side. And I'll also talk a lot about Mr. Andy Witt, who is Director of Quality for NMH for Ambulatory Operations, who has really also helped us get in to have the ability to have the ear of the entire health systems quality team to bring to leverage healthcare improvements, quality improvement in the health of sexual and gender minority patients. So a bit more, we've been doing some strategic planning efforts within ADVOCATE, which we only launched as a program about 2 years ago, back in October of 2022. And we really wanted to make sure that we developed a strong strategic framework to do the work that we're doing in the health systems that we work with. And so right now, our mission that we have is to advance clinical and translational research in SGM people and people with HIV for maximum health equity impact in partnership, as I said, with patients, communities, and health systems. We have an impact-focused approach to our mission, I think is what I'd like you to take from that. And then we have our vision. Right now, we're thinking about a 5-year vision, and we're defining the meaningful improvements we want to make in the delivery of healthcare that can actually improve health equity in terms of health outcomes in these patient populations. Our values are intersectional, to take an intersectional approach and frame to all of the work that we do. Co-design is really focusing in, again, on the partnerships that we have. Equity is what we are striving for our impact, and representation in our teams that reflect the populations that we are seeking to serve. And we also have cross-cutting pillars that we're developing goals to operationalize this plan in terms of training the next generation of the workforce with our education and professional development goals, research, practice, and policy. So you again see our logo here, which is translational, an approach of translating research to practice in healthcare in particular, or also into community programs and evaluation, and then policy impact, thinking about that at both health systems policy, one health system at a time, but also making changes in state and federal policy and law. And I am trained not only as a basic scientist for my initial doctoral work, but also as an attorney specialized in health law and bioethics, which has been a helpful foundation to have in the program alongside the clinical expertise of both Dr. Otto Rivera and Dr. Sue Jordan to help us with these foundations. So I mentioned the Gender Pathways Program. I just want to also recognize that GPP truly is a partnership unto itself. And ADVOCATE, we're working towards launching a bigger platform coming soon. Can't quite reveal it all yet, but there will be a Gender Pathways research program that's formalized in the beginning of next year. and really, again, having this lens of like SGM or sexual and gender minority healthcare quality with this focus on trans and non-binary and gender diverse patients that will be part of the work. And also this partnership with the larger health system, which I mentioned. And so you can see that I want to also highlight that it's not just the downtown work that we're doing within the health system, it's the full health system. Because, for example, the electronic medical records data warehouse that we've been building draws from all 11 hospitals within the unified Northwestern Medicine Health System and the regional network, the health network that is affiliated with that. So just a bit more, like it's also been really helpful for me to have served as a member of, now I think it's a little bit in the redesign phase, but there has been, there was a quality equity working group within NM that as a non-physician, I feel privileged to have been able to be a part of and learned a lot about the patient's first mission of NM and how that connects safe care, clinical excellence, and integrated care models to improve quality through an equity lens. And so this has also been something we've learned from and drawn from over the years to inform the approach and from being quality oriented. And also I want to mention that part of this partnership has also meant that we align the metrics that we're using to look at and think about health equity to those that are used by our health system partners. So for example, the Northwestern Medicine ambulatory quality team looks at a number of different quality metrics that are put out, for example, by CMS. And so we have actually been able to partner with analysts on the side of the quality team, the analytics team, on the side of the EDW with our research side of the EDW to define like what are we going to think about moving that could be meaningful both to patients and to our partners. So through the different strategic planning efforts and just work that we've done through the quality lens and committees that we've been part of at Northwestern Medicine. And also I want to mention that my team has also partnered extensively with Howard Brown Health and increasingly also the University of Chicago's health systems to think about a model that we're building to improve in particular the health of LGBTQI+ populations and people with HIV. And we were calling it the ADVOCATE model, and obviously that's the name of this program, but we really are thinking about the model as leveraging quality and translational sciences to improve the population health of SGM people and people with HIV. And so we've organized ourselves into 4 teams within the research side, and then we really thought hard about how the work that we're doing on the research side of our team with this program is mirrored within the quality approach for building learning health systems and actually making an impact on patient satisfaction, that patient first mission, as well as health equity and health outcomes. So the first theme that we have here that I've already mentioned is our EMR data core team. And so in this team, we have built a series of datamarts that I'll talk about more in depth and later in the presentation that really allow us to identify all sexual and gender minority patients in the health system. And then we're also using best practice approaches, thinking about common data models like OMOP or the PCORI common data model or others to think about how we can build phenotypes using EMR data that could be translatable or reproducible across multiple health systems. We also have developed an intervention team within ADVOCATE that's really focused on the development and then piloting of health system interventions that would be able to close equity gaps that we see in the data in our data warehouse. We also have a learning health systems team that is seeking to take the evidence-based interventions that we and others in the field have piloted that can be known to work to close equity gaps and actually take them to scale, which is really the phase that we're in now, is this translational phase of building interventions and starting to take them to scale. And then we have an advocacy and policy team, and we partner a lot with our community organizational partners here in particular, such as Pride Action Tank, AIDS Foundation Chicago, SAGE, GLSEN, Equality Illinois, others too. Then the Governor's Commission on LGBTQ Aging, for example, to actually identify what are meaningful types of laws and policies, in particular in that coalition within the state of Illinois, that we can get done together. Because while we are here in the academy for the predominant housing of our team or in healthcare with NM, people in the community have teams that are thinking about governmental affairs or going down to the legislature specifically for LGBTQ community health. And so they can center things from that frame to help us do things like pass the state law in 2021 that required 10 state agencies to collect SOGI as well as race, ethnicity, ability, language, and accommodations, et cetera, within all major projects of those entities. And then to take the data that they have and put it into a centralized database tracked by the state, so that we actually have the types of diverse data across entities throughout the state of Illinois that will allow us to do better, again, to improve the health and well-being of LGBTQIA+ people across the state. And you can see what we have a mirror here. I think maybe people here, I know in IFAM, you've talked a lot about different quality models and processes. And so here we've learned a lot also from Mr. Andy Witt talking about when the quality team at Northwestern is seeking to close a gap that they've seen in the data, that they first do measure build and they work with analytics teams. They then think about developing process improvements, doing root cause analyses, and they have the health equity playbook, which is outstanding. It's been developed by Diana Shu and Teresa Pollack and others in the quality team with that leadership. And then they would take to scale things that work to pilot, they've piloted to increase, whatever needs to be done, like depression screening, fall risk screening, et cetera. And then you can monitor the impact on the health, patients in the health system, again, through partnerships with analytics. I want to say that this model is kind of put in these diamonds, but you could also think about everything having a bidirectional sort of relationship and really forming a circle approach, because it's a continuous quality improvement feedback, which I'm shown here. Like, this is more of the classic learning health systems model, which I think we also draw from with DMAIC, design, measure, analyze, implement, and then continuous quality improvement through evaluation. So I've talked a little bit about this journey, but I want to say that back in 2019 is really when Northwestern had a unified Epic instance that went live across the entire health system that included the SOGI smart form, as it's called, within Epic to collect sex assigned at birth, sexual orientation, gender identity, anatomy inventory, and then social and medical steps that patients can take to improve gender affirming care and like thinking about social transition, et cetera. So it tracks all of those things, and that was added. And I had the pleasure to consult at that point with Dr. Cynthia Barnard to help with designing the rollout and what are the measures and what are the response options at that initial time within the SOGI smart form. And then we gave a grand rounds that was in partnership also, not just with NM, but with ISGM's LGBTQ current issues talk. We were added to this committee, both Dr. Jordan and I, for quality equity. And then in 2022, Advocate got launched as a program, and we started to do immediate work with funding from NCI. We had a supplement project that was funded to scale SOGI, or sexual orientation, gender identity collection within the oncology space, in particular within several clinics within the Robert H. Lurie Comprehensive Cancer Center. And then following that, we've found some additional support through the ISKI project within the Third Coast Center for AIDS Research, directed by Dr. Brian Nastansky. And we've been able to start building additional R-level applications from these pilot projects, and have been able to also do a system-wide effort. We consulted on the launch of the legal sex X, or gender X. I might have seen there was a Chicago Tribune article about that. My team within the Advocate group in the Reach Lab did over 40 trainings in about 6 weeks across the health system as part of that launch. And I see some of the people here who invited us to speak, and thank you for giving us that platform, because we have had an impact in actually moving the needle on SOGI data collection, and we continue to move forward on this journey together. And so what I wanted to talk about more next is this work that we did in the Cancer Center to start to figure out how do we scale SOGI data collection. So I want to note that while we received a pilot or an administrative supplement, I should say, to the Cancer Center support grant for this work, we were one of several sites. I think across the country, there may be 15 to 20 sites that actually participated in a learning collaborative, because the NCI is extremely interested in learning more about how to do better to collect this data to inform patient care. Because I would argue that SOGI data is critically important, not just from a lens of knowing who patients are, but knowing how to treat them, especially for cancers. Because if you don't know what somebody's anatomy is, how do you know what cancer screenings they should receive? There are also differential recommendations, for example, for HPV vaccination for gay and bisexual men, which even at older ages are now within certain different clinical practice guidelines stated that these populations should be receiving these vaccines more so. And so if you don't know the SOGI information for your patients in your health system, you can't even follow best practice guidelines or care for these patient populations. And so the NCI has been aware of this and was really passionate about putting some funding into improving the collection of data for that reason in the space of oncology. And there's been a number of papers that have come out to investigate barriers and facilitators that will help or hinder the ability for that SOGI collection to be done well and at scale. And so I'm showing here findings from a paper in JCO Oncological Practice that found that in a survey of ASCO members, which is a cancer professional society, just to avoid all the jargon, that the prevalence of SOGI data collection that was reported by these members was 40% for sexual orientation and 46% for gender identity in terms of the percentage of institutions that were collecting the data. Many respondents to the survey felt that, but not all, felt that knowing this information was important for providing high quality cancer care. And the top factors that came out as important for allowing this uptake and implementation to occur were leadership support, dedicated resources, and then the knowledge that SOGI is actually important for patient care. So we took a look at this literature. We also took a look at what this landscape looked like within Northwestern Medicine through our work with the quality committee, as well as just our partnerships. And we then, of course, had the funding obtained that was allowing us to meet this bucket here from like dedicated resources to help us kickstart the process at Northwestern. And then we also noted that the ability, like in terms of policy, to make the case that this is important to be done was starting to evolve more in Centers for Medicare and Medicaid Services too, with the Hospital Commitment to Health Equity measure, which is a structural attestational measure for quality departments. The CMS is indicated in the Federal Register that they will roll out to more and more and more facets of health systems, not just inpatient care, but also now moving into oncology care and to other parts of the ambulatory care setting. I think what is going to be targeted by this. And again, you just see, if you read through these priorities, which there's a link to get into that more detail if you'd like, that really a learning health systems approach for building equity that follows, again, this translational model that Advocate has put together in partnership with Quality has in it. And we also knew that in addition to like all of the leadership investment and the resourcing, that it just needs to be a good idea and feasible to do. And so we knew from the literature that this was possible to do, at least in primary care and emergency settings, and that we knew that people are starting to do this work in oncology besides us with the funding from NCI. And we just know that it's been studied for at least the last decade and found to be highly acceptable that patients will answer the sex assigned at birth, gender identity, sexual orientation questions in healthcare, in particular if it's seen as unremarkable. So if the SOGI questions are part of a longer list of questions that are demographic in their nature, race, ethnicity, ability, language, marital status, insurance, address, age, all of these things, and SOGI is just part of it, then people think of it just as, okay, yep, this is part of all the questions and the details about me section. It's just standard practice that I'm going to get asked that. And that also there's been some research showing that patients often want to have some privacy around this data collection. So self-report works well, especially if you have people who are MyChart users. You can just push the questions, I would say on an annual basis, into details about me, and they will just answer them. And then also the refusal rate for these questions is comparable to race and ethnicity. The refusal rates for income is actually by far the highest type of refusal that people will have on these demographic questions. And that SOGI, again, if it's just part of a longer list, is seen as part of an unremarkable list of things that the health system is collecting for all patients. We're doing some testing now in my lab too. We have an additional R01 that's funded seeking to improve SOGI measurement, including within healthcare contexts. And we're thinking about testing a hover over approach. Like if patients are in the details about me and they want to know why are they being asked, then they can have a little, like if they're on their web browser in particular, can hover over like a little icon and find like, well, we asked this to improve patient care. We ask all of our patients this information because that's usually what they want to know. And if they're reassured about what they can, what will be done with the information, and then obviously HIPAA exists and their data is private, then there's no difficulty with collecting this. So that was really the backdrop of what we put into our application. We had 3 aims in our application, which is building upon this background knowledge. Can we identify barriers and facilitators in the Robert H. Lurie Comprehensive Cancer Center setting to increase SOGI data collection at scale? And then we also developed a training, which we obviously implemented not just within this project, but in the larger Legal X project. And then we wanted to assess the effectiveness of our trainings and our approach with building relationships and partnerships with our health system partners into, can we actually move the needle on data collection? And so we did this with a mixed methods approach, which my team does a lot, both not only with quantitative methods and epidemiologic approaches, but also with qualitative interviewing and implementation science frameworks to inform these types of health system approaches. And I've learned a lot from Dr. Betas here on that, so thank you. And so we have gone through and we did a series of qualitative interviews with people in different positions in the cancer center. We also reached out to the patient family advisory councils, the gender pathways programs, community advisory board, and other groups. And then we did trainings we partnered with clinical practice managers to be able to do these educational trainings. And then we have set up the Datamart. So here's our team. So here's the picture of Mr. Andy Witt right here, as well as, again, Dr. Jordan, Dr. Barnard, and team here, including Paul Nelson and Jenny Holtz, Reese Owens, who are full-time staff members within my lab, as well as Deja Glover, who is actually housed within Northwestern Medicine's quality team and reports to Mr. Andy Witt. But we have a relationship where my team actually will send part of Deja's salary support is the SOGI Collect supplement at the time, or other grants that we've had come in. We actually are able to partner, and I did the same thing with Howard Brown, sending funds to the health system to actually cost share staffing to people who are going to get the work done across the institutional lines. And we also have Dr. Paige Hackenberger, who is now in PGY5, a plastic surgery fellow here at NM, who works closely with Dr. Jordan. And then Dharmesh Patel works with Andy Witt and has got a lot of very tremendous relationships across various clinical practice managers and really everyone in the NM health system, as far as I can tell. Amazing. And then also don't want to leave out Mr. Kevin Hasher, who is a medical student, a MD, MPH student here at Northwestern's Feinberg School of Medicine, who is really excited and interested in, does a great job with thinking about delivery of educational trainings and helping to improve practice from like a peer-based approach as somebody who will be a future attending physician doing, I think, very impactful work as well in these spaces. And I want to mention here, this is a quality charter, because on top of IRB approvals for all of the work that we do with our health system partners, we also seek quality charter approval so that we speak the language of what matters for approvals across the different systems and contexts we work in. And then really just to say that this right here is just to say that other people have been thinking about this. And one thing I want to point out from here, the IT infrastructure piece, there's a lot of variation nationally in terms of what cancer centers are able to do with improving SOGI data collection, because not all of them even have a SOGI SmartForm and Epic that's live and embedded across the whole health system. And so that's an advantage for us with Northwestern that we have that done. And we did update that with X during the SOGI Collect project. We actually updated an IT field to include X as a legal sex in the midst of this implementation work. So that was just something I wanted to note. So in terms of our AIM-1 activities, we had I think 15 total key informant interviews within 2 main clinics within the cancer center. the Polsky and the Daily Center clinics, and you can see the different roles of people that we were able to engage and speak with across like a 360 approach to thinking about patient care experiences, not only talking to physicians and training physicians, but oftentimes in oncology, in terms of the roles and responsibilities breakdown, it's not often a physician or a surgeon who's going to wind up asking patients these questions. It might be more likely to be a medical assistant or somebody in a variety of nursing different roles and contexts. And so we wanted to make sure that we talk to everybody, including also clinical practice managers, because they're often the people that if they don't support something like this, then even if higher leadership says is in general, it's a good thing, if there's not like a mandate to do it, then clinical practice managers being unfavorable or thinking that asking these questions is not important will mean that it's not done as frequently or as implemented with the same fidelity as if they were or are supportive. And so we have now, this is under review. The findings from this work are under review at JNCI Monograph as of this past month. There's a special issue that will come out in that journal that is focused on describing the findings from all of the different NCI supplements that we're seeking to scale SOGI data. And you can see that what we found in the NM context or the cancer center context about what are barriers and facilitators for SOGI data collection exactly mirror what's been found nationally that I've talked about so far. And so people felt that key facilitators is that there needs to be capacity to collect the data. So the who will collect was a big question people had. Then there needed to be education and recognition that collecting this data was important for informing patient care. And that people also, just like patients have reported, wanted to make sure that this wasn't asked maybe in the waiting room for everyone to hear, but was instead part of either a self-report situation for patients, either on MyChart or perhaps on paper or in an iPad, et cetera, or it was a private conversation once they were roomed, was something that came out. And also people just wanted more information. They felt that if people understood the best practices that have been well documented now, that if you just ask this as part of a normal set of demographic questions that people answer, they needed to know that that has been tested and was actually evidence informed. Barriers are kind of like the opposite of facilitators in some ways. And one thing that I wanted to highlight with the barriers, though, is that people would say, like in the facilitators, it's okay, a facilitator is, I think it's important to collect, but not for me. I think someone else should collect it. I don't think that I have the time. And everybody says that. Like, doesn't matter what their role or background is. Everyone's like, I'm busy and maybe somebody else should do it. So that really said to me that part of defining a model to scale the collection is going to be within a given clinical context, like who on the team is accountable. And how do we know who to talk to, and how do we build rapport around showing reports, for example, about how a clinic is doing with the data collection? Like who is the champion, if you will, for being accountable to make sure that this is done if patients do not self-report it. We had a lot of great suggestions that emerged for implementation in the NM context. There are people who liked and had heard nationally about this concept of we ask because we care. And I like that too as a slogan because it really emphasizes caring both in terms of people in the community as an entity or as like a concept, but it also care can be thought of and echoed in terms of patient care. And so we ask because we care was something that a number of people said, making it standard, having it clear who will be collecting this and it should be done in private, et cetera. And then there needs to be coordination across teams. So sometimes especially if the who for collection is not clear, you might imagine that a person who's passionate about this, who could be a patient service representative, a medical assistant, a nurse, could have gone through and collected the data, but they didn't tell the next person that they collected it. And maybe the patient has divulged to that person, these are my pronouns, but then the next person doesn't know that and uses different pronouns than the patient prefers. And so there needs to be coordination, and people talked about that through some of their own experiences, having misgendered patients and wanting to think about systematically how to approach ensuring that patients are always referred to with their correct name and pronouns throughout an entire cycle of a visit. And yeah, I think that that was really a lot of what came through implementation. And then we asked about the how, the format too, because for training, academics can sometimes think, I'll do a 4-hour curriculum and then I'm gonna put it on and people will be required to take my entire 4 hours. No, people want tip sheets. People want scripts that they can have maybe even on a tip sheet for how to ask patients or get information from patients that will help with these topics. And also there's turnover. And Northwestern Medicine is a very large health system and people are coming in and out all the time and it's continuously expanding. And you might acquire a new hospital and that hospital may not have the same culture or experience with asking these questions as the others in the system. So like making sure there's an approach to ensure everyone gets the information, having reoccurring settings for the trainings to take place, and also using best practices in education. Don't just, if you are going to have more like a 15-minute training, perhaps during a standing meeting when people are meeting to talk about what their day or their practice, their operations are going to look like for that day in the morning, that you want to really follow the format that people are used to in terms of case studies or like examples and talking through things in a way that's applied and not just theoretical in terms of training preferences. And some people are like, just as long as I get the training, I'm good. I think it's important, which we appreciate. So for those of you who are patient-facing in your work or who do have the occasion to get into Epic, I just want to show you that you can actually access the SOGI Smart Form within the face page of what your view will look like. And so the arrow here is pointing to where you would be able to click to bring up the storyboard and then get into this SOGI Smart Form and what it looks like. So here are some more of the options, like within the Epic context within the health system, what it looks like, and how you can have the different selections for gender identity, sex assigned at birth, and pronouns, importantly as well. You also see sexual orientation identity at the top. Interestingly, sexual behavior is in a different part of the electronic medical record, the social history form. So it doesn't actually show up here as far as we've been able to tell. And then again, I talked about the affirmation steps, and it's not every single health system has the exact same look or way to access the smart form. There is variation in Epic instance, and obviously not every health system uses Epic. We actually have it's so new, I didn't even put it in this talk yet. We just had a paper get published in JMIA, the Medical Informatics Association's journal, that describes the variation nationally across all the different EMR major platforms that have above 90% market share in total and how they ask these questions. So that is something we've been looking at systematically because we're thinking about, here's what we've done at Northwestern Medicine, but we're thinking about how could this be also a national model that others could follow. So we're publishing on that. I'm not going to go through all of these different, I'm not really trying to do a clinical training here, but just to say we have had some, we have some tip sheets developed that are in the MyNM Learning Exchange portal that really go through like how do you ask these questions, and not just for sexual orientation, but for gender, sex, et cetera, sex assigned at birth and legal sex. And I already talked about this, like the tip sheets also go through the common concerns and how to help people feel that they can answer and meet the challenges to overcome any sort of apprehension about collecting the data and to just do it. We've also, this is not, I want to say, the workflow that's in all Northwestern clinics, because there is not one workflow that is universally used, because there's many types of patient care that people in different primary care or specialty settings might need to have different clinical operations for different reasons. But in terms of a suggested best practice type of workflow, we did develop this as well from our work that we've done. And we would suggest that pre-visit that the best practice would be to send patients a text or a MyChart push to have them fill in details about me, including SOGI, as part of that list. That we also, if patients haven't filled that out, like one thing that we know that will have to happen when people are registering in person to say they're there for their visit is often the patient service representative is going to look at their identification document. And so at that point, we would want people to be recording legal sex that aligns with legal sex would be aligning with their identification documents. It's also at registration is a great opportunity to make sure that people know that they are referring to the patient's name and pronouns correctly. And there has been some great work that's been done by Dr. Roseanne Vasiloff and team out in the north side of Chicago that has the Lakeview Clinic that really, they've done a great job with this, like starting from the front desk all the way through the entire patient experience and visit to ensure that patients' name and pronouns are documented and properly updated so that people get referred to properly throughout their visit. I want to note that this applies to all patients. Nobody likes to have their name wrong when they are going anywhere, including to the doctor. So people might use their middle name instead of their first name. People might use a nickname instead of their name on their driver's license. And sometimes it's so true for people that if you call their first name, they don't even know you're talking to them. And so this is important for many reasons for many people, and it's just a best practice, I think, to support registration. And then we would suggest, because of the concerns that both staff and patients have expressed about privacy, that it's at once patients are roomed, if they don't have all of their SOGI information on file, and because it's also part of patient care for the care team to know the information about the patient, that's when we would suggest that either a medical assistant, a nurse, or a physician, or advanced practice provider, et cetera, of PA, people of that type of like clinical training background be the ones to ask these questions if it's not coming through the self-report from the patient. But yeah, that is where we're at with the first part of the talk. Am I allowed to stop for questions? Or, because now we're going to go in more in the Datamart. But any on the webinar so far that people have had? Okay. Yeah, I can just do them before we get in.
Yeah, we'll take a quick break for questions. We have two online. The first, how does this work, if at all? Is the team working with Northwestern University at large to impact their LGBTQ plus practices? For example, changing job application gender options to be more inclusive, policies, all gender bathrooms in public buildings, et cetera.
Yeah, I think that's a good point too, because part of a 360 view of patient experience is also, can they go to the bathroom? Full stop, right? Can they find a bathroom where they can go? Also, this again applies more broadly than only thinking about, say, transgender patients, although it's really important to serve transgender patients well with high quality care. It's also important for people with disabilities, for example, who might have a care attendant who has a different gender than they have, to be able to go to the bathroom with that patient respectfully, with dignity, and without fear. And so this, I think, yes, we have to think from that view. And I think the other question is workforce, maybe. But that was a university workforce, but also it could be the same question in the health system workforce context. We have not started to work on the workforce questions as much. I do know that there are independent efforts, including some led by the community, with Kim Hunt and Pride Action Tank have developed a map of all gender neutral and bathroom spaces in the city of Chicago. Like, they're adding to it all the time. And they even have businesses and public accommodation types of mapping in that map that has been put together. And there are a number of university bathrooms in that location, in that mapping that's been put from Northwestern. And I think more should be done. And I think in terms of workforce too, many employers, including both Northwestern University and Northwestern Medicine, do not ask employees their information around SOGI. And they could, because there's plenty of places that do this. And the American Medical Association has developed policies saying that this is a good practice. There's guidance. My colleague, Dr. Carl Streed, who's at Boston University Medical Center, has done a lot to work in this area in particular to try to say that we should really be getting this done, because it's also important to know that having this information helps build an affirming and inclusive workplace culture. Because one thing that I didn't see come out as much in the literature, because I just don't know if people have asked it quite this way, but another thing that can promote SOGI being asked is an affirming workplace environment. Like, if people feel that they are seen and that they are important and that they know that the employer is also caring about providing a good experience for them as employees in terms of being an LGBTQIA+ employee, then I think that also could help facilitate a culture of caring. And so that is something that has not been done I think I can announce this. I just, as of December 1st, have been named within the Cancer Center an assistant director of DEI, as well as clinical trials equity for LGBTQ populations. And so part of that role does include a workforce scope. So it's not that, I think there's conversations that are possible and have been starting to happen, but I do think I'm glad that we got that question now, because I think that it's an important thing to also highlight from this implementation and culture perspective, going into our evaluation component of what we've set up with the ADVOCATE system, which is our electronic medical record datamarts. So a little bit of a visualization of what does our Datamart look like. So at the top here, this is just the entire data warehouse as we conceptualize it. And within the data warehouse, we have a variety of data marts or data sets, you could even think of them as being. And so on the left here, it says NM Data Mart SOGI inclusion criteria. What that means is that we have actually set up a system-wide data pool in partnership with our electronic data warehouse here. Our analyst is Mr. Stephen Pan, who we've had the pleasure to work with for the past 2 years to get this done. And we have been able to find the SOGI Smart form, find the social history form. We've also been pulling social drivers of health tables. We've been able to get patient address into the identified version of the data mart you see there, to be able to do geocoding to calculate the area deprivation index for all patients in the data marts. We also have a variety of different outcomes, because we started when trying to figure out what do we pull into this data mart for thinking about health outcomes to consider. We actually just I'd done quite a bit of EMR data work for other NIH-funded projects in all of those data pools. I got a blanket IRB, wrote a separate IRB. Actually, Dr. Paige Hackenberger really led this. Thank you, Paige, if you're listening, to get a blanket approval for all of the different studies and the different data request forms we had. And then we also worked with the quality team to make sure that every single data point, whether it was labs or diagnoses or procedures, or we have surgery tables, operating room tables, appointment tables, encounters, visits, like the whole set of everything, which I have a schema for as well in a visual setting to get into the data mart. We got that done. And we also ensured that we had different levels of regulatory approval or determination within these data marts. We have a de-identified data mart, which of course that will not have any HIPAA identifiers. We don't have patient address, we don't have patient medical record number, we don't have the visit dates in our de-identified warehouse are date shifted by a year randomly, so they actually will meet the criteria for not being identifiers under HIPAA. Then we have the identified data mart, which I've talked a little bit more about, having information that lets us know the birth date, the age, the actual address, location, for patients. And then we have what's the SPHI is special protected health information. There's a state law in Illinois that said that you need special patient release to have people be able to look at their mental health, developmental disorder, or disabilities, rather, it's a better word, and also substance use disorder treatment history. So we have a separate approval to be able to have a data mart that would only allow the only people are in who have the separate waiver signed for that, so that we can still do the very important work of looking at mental health and substance use in populations, which are known disparities for LGBTQI+ populations and people with HIV. So we did get this regulatory approval set up, and we've been able to, our first data set was, I think, last year. We got our first one maybe in May of last year, and then we've been setting up an automation system so that we actually, for the identified data mart, are getting updated demographics, including SOGI, race, ethnicity, ability, language, accommodation status, social drivers of health, contraception, there's a social history, a lot of factors are updated every week. And then we are able to also have the full outcomes side of all of the other files that we've got are updated monthly. And then we have quarterly updates on the de-identified data mart from NM. And then we also have an outcome inclusion criteria data mart. So everyone on the left has, if anyone who has SOGI smart form data on file is going to be on the left-hand side. And then we also are epidemiologists, so we wanted to know our denominators. And so the next NM data mart you see here, which you also see a UChicago companion data mart from another health system with the same inclusion criteria here, anybody who has ever received HIV screening, cancer screening, has an HIV diagnosis, or any cancer diagnosis has been pulled into that Datamart as our denominator Datamart. And that would include people who do not have SOGI on file. So what that means is, because we have in our outcomes for SOGI all of those HIV and cancer screenings and diagnoses, we can compare people who have known SOGI on file to those who do not, to see how our different estimates would vary, but from everyone who's had these different procedures, tests, et cetera, in the health system versus those who have SOGI on file, if that makes sense. And we also have a Howard Brown Datamart that is a limited data set that is from January 2010 to the end of 2020. And these Datamarts, I should say, they also start January 1st, 2010, and then are being prospectively updated as I described. So we have a lot, and we have, I'm not going to go through all of this, but we do have a lot of documentation that we built out and reports that we have that can be run every week to understand who's in our Datamart, who's answering SOGI, maybe taking out their SOGI answers. What does this look like? And we have a month-by-month wave of the data set that we built out with documentation. In terms of thinking through where we're at, when we looked prior to our team's work within the Cancer Center, we actually were at between 6.2 and 10.9% of all NM patients having, in that case, pronouns and gender identity on file. If you looked within the Polsky and Maggie Daly Women's Health Clinics, you could see that those numbers were already higher at that time, but still there was work that could be done. And then if you look on the right-hand side of this graph, we looked at a period of time that was following our trainings and into the new year. And we were able to see increases, somewhere, typically it's been about a doubling of the data collection that we could observe. And it's still a very short time frame for these metrics following both the SOGI and LegalX collections. In terms of where we at, like system-wide, a bit more in terms of who has the SOGI smart form on file. My team ran this week's extract. So thank you, Best Lens, for doing that, because you're not on the earlier slide, I realized. But we have over 700,000 people to date in the NM and SOGI Datamart inclusion. And so that has increased in December of last year. That was at 600,000. Now it's like 710,000 people. We're often getting, a couple thousand up to, it depends on the week, but we were able to see week by week meaningful increases in people with the data on file. When we look at sex, there is variation, though, about which question that has more answers than others. So sex assigned at birth was about 300,000 last year, about 360,000 now. Gender identity was 380,000 last year, just over 440,000 now. And then sexual identity over time, for sexual orientation identity, it was the lowest. It's just under 260,000 last year, but over 300,000 now. And then there are also people who have anatomy inventory on file, and that drives kind of the rest of what we see in the Datamart. I do have a breakdown of what we've been able to see by these different criteria for tables for that too. So the health system has more people with sex assigned at birth female than male. And then if we look at unknown or not recorded, or X, probably people want to see what X looks like. It's we've had some uptake, but the vast majority are, say, male or female. If we look at gender identity, you can see here, first, I want to point out, of those who've been asked, less than 1% did not disclose, right? So people answer these questions, first of all. And again, we see those similar male and female numbers. And then by gender identity, we can see that just over 0.5% of people in this data who have this information on file are non-binary. And we also have about 0.25% of people who are saying that they are transgender female or transgender male. And collectively, it's a bit over 1%, which if you look nationally, estimates for transgender adults are about 0.6%. And some of the last systematic review that I remember seeing, and for youth, it's 2 or 3% nationally. And these are adults. Everyone in here is 18 and older in our Datamart that we're seeing. So, and if you also not just look at these numbers, but you're comparing sex compared to gender. And we also have a gender pathways program flag for who is a GPP patient, which people in GPP are accessing gender affirming care. Then we get almost 7,500 TGMB patients that we know of in the health system to date. And if we look at sexual orientation, it's 89% report straight. And these numbers, bisexual is 2.5%, gay or lesbian 4.5%. We do see like a little bit less than 1% of don't know or something else individuals in terms of how the questions are structured. And so I wanted to let you know how this compares to all of us, which also we're a site, Northwestern's a site to recruit for all of us. And what you can see is in total, just under 750,000 people have consented to the All of Us study. About 500,000 or a little over have completed the initial steps of it. 400,000 people or so have completed the basics, which would include SOGI questions in that basics demographic survey. And about a quarter of those have completed social drivers of health questionnaires. And if you look at their numbers, they're not that far off ours here. 87% of the people there said that they are straight. And then you can actually see one thing I'll note is that the numbers here are flipped with more bisexual than gay or lesbian participants, which is more typically the case in national data sets, which I can show. And again, prefer not to answer, very low, like 1%. People will answer these questions. If you look at sex assigned at birth, quite similar numbers actually to our health system again. I want to note that 0.02%, they actually have an intersex option in the sex assigned at birth questions in all of us. And there are people that can be found within this cohort for intersex. And then in total, there are about 3,980 trans or otherwise non-cisgender patients in the All of Us cohort, which is about 1% of the sample. And I'll note here that this isn't comparing people in terms of sex and gender. But regardless, what I want to highlight is that one thing I want to say, I don't think it was on my slide, just over 31,000 patients in NM in our Datamart, our SOGI Datamarts, are sexual and gender minority patients. And that is, I think, it's very comparable to all of us. Our numbers look pretty similar to all of us. And we're not even like, we're at 20% data completion, right? In terms of the overall health system. And as we continue to implement and scale, we will far surpass the numbers that you're seeing in all of us to be able to think about doing health services research with LGBTQI+ patients in one health system alone. So it's powerful. And there's a need to build a national, for every health system to be doing this, because we can and should be doing better with these topics. And nationally, 7.6% of all US adults are LGBT. You can see the breakdown here. And you also just note that the majority of these patients are bisexual. Here it's 0.9% are transgender. So like the representation in our health system, at least for those who have data on file, looks pretty similar to national data, and similar for maybe a little higher even than the national answers from Gallup polling data for who is in Northwestern. But with that, I think I'm about at time, and I want to just say thank you to sources of funding, both to NCI as well as to NIAAA, and for, in particular, also Dr. Brian Mustansky, Dr. Lee Platanius for letting me have administrative supplement application opportunities to jumpstart this work. And I'll end with my contact and say that we're open for collaborations and appreciate your time and attention today. Thank you so much. Now let me turn off mine.
Thank you so much to Dr. Beach for that remarkable presentation. I want to start by seeing if there are any questions in the audience. It sounds like there was one more online. No? Okay. While you all are thinking, I will take the liberty of asking a question. This was such a tremendous kind of representation of a really robust and successful partnership between your team and the health system. And I'm curious if you might reflect on kind of what the kind of core magic ingredients were to allow for this to work and into the future from like a sustainability perspective. So if you had to boil it down to those core ingredients for others who might want to be thinking about doing work in their areas of expertise, what would that look like?
I thank you so much for that question. I have tried to think a lot about this because it's important for the national model too. So I think people and relationships first. And it helps a lot that Dr. Cynthia Barnard had reached out to ISGM, because we have at Northwestern ISGM, right? Which is a large and robust program. I think we have over 20 core faculty, of which I'm one, and also Dr. Jordan and Dr. Rivera. And they reached out because they knew we exist. And so then they started the conversation, and then I raised my hand to follow up. And there were no resources in place at the time that I followed up. I just knew it was important. And then I kept showing up, including to all those monthly quality equity calls. And eventually I got to be known as Dr. Beach in those calls, which is when I developed a rapport, because I'm not a physician. It felt like a magic moment to me to get called Dr. Beach in the health system. It was remarkable. And that was helpful. And then just going to lunch, I definitely am authoring papers. Like, we're seeking to publish this model as an innovation report in academic medicine is what we're seeking to do. We're presenting it actually next week at the Institute for Healthcare Improvement at their national meeting. This talk, a version of it, will be presented there next week. And I think that was it too. Like, I found out that also NM was interested, including in the quality team, to participate more in research. And so another key facilitator was applying for grants together. We needed to be able to have resources with a shared objective that brought us together to keep meeting. And so pilot funding, whether it is from NIH or internal sources, is really key. And I also want to give a shout out to Jen Brown and ARC for all the work that they do to make opportunities available to make these partnerships blossom with community partners. But having dedicated time and resources was another key thing. And then just being like-minded. Like, we share values. Like, I really believe, and it's been amazing to work with Andy Witt, because he is so passionate and cares so much, and it's important to him personally too that this work be done. And it is to me as well. I'm also, like, here I am, like, I'm out, like, you can see all the color schemes. Like, I'm a part of the community. Like, I identify as bisexual, as non-binary myself, and it's representation, which is why that's one of the values of our program, is that I think when it's your life, then how can you ignore it? It's your life too. I don't like being misgendered when I go to the doctor. I don't like not having people, not having an understanding, like explaining my own healthcare to my care team. Like, I know we can do better, because I've seen it, and I know that we can make it happen. And I feel like it's that dedication and passion that also is a magical driver.
Thank you for that response. And I know, given the work that you're doing with your team and others, that vision is possible. Any questions from the audience? Anything online? No. Then I might ask you, Lauren, to close with kind of what you're most excited about that comes next.
I love that question. I am really excited about continuing to develop this model and find additional partners. I'm excited about the data warehouse and the possibility of using that to drive forward change. We had a paper that showed, Dr. Jordan and I, in an earlier version of this Datamart before it's in its current form, that showed that depending on the metrics used, 2% to 50% maximum of transgender and non-binary patients were getting their recommended mammograms at Northwestern Medicine, compared to over 77% of cisgender women. And I thought, 2%, anything we do, we can do better. And it's not just Northwestern Medicine, mind you. This is nationally too. It's just that we have the data to show it, and the data to show it, combined with partnerships with quality committees, the hospital commitments, the health equity measure. If we can get SOGI into those data dashboards that are like stratified, then, which we've had a hard time doing, because people keep saying, well, the data is not complete enough. The data is not complete enough. I'm like, we have 700,000 answers. When will the data be complete enough? I think there's a huge opportunity there to move forward and actually do better. And I'm also trying to rise to the challenge of applying, including with you, Dr. Betas, applying for funding to scale the data system-wide and build this evidence-based model for doing systems change work, and not only in oncology, which is extremely important, but also the entire health system. If we can get there and we can build this, then I really think we can actually close gaps in health outcomes for patients in an extremely meaningful way. And that is why I come to work every day, even in the cold.
Well, let's give Dr. Beach a round of applause, and thank you so much for this incredible presentation and for your attention.